Q&A button in the like down in your options. Please continue putting your questions during the session. You can also put it on in the chat, and I will read it at the end of the session. So all Q&A will be toward the end. We will do aiming to have the session for 45 minutes, followed by 15 minutes of session. We will like to do a heartfelt felt thank to the APPNA MERIT Leadership and Organizing Committee for creating this valuable platform to share innovation and research in healthcare in Pakistan. There is a WhatsApp group and there is a YouTube channel. Waleed is going to post the links. If you are wondering what this platform is doing, you can always join. Special thank you to Waleed for managing all the technical aspects behind the scene and making it a seamless experience for all of us. And our valuable panelists, that is Dr. Akhtar Hamid, who is a pediatrician consultant, and Dr. Sarwat Hussain, for always being here to support all the sessions. And then with this, I will introduce my very good friend, colleague, brother, Dr. ADEEL KHATRI. It's my absolute pleasure to introduce him because I have been working with him now almost 6 years. And ADEEL, I was reflecting on it and I could not believe that 6 years have passed. And he will be
Yes.
talking on Pakistan healthcare landscape from the lens of simulation lab in low resource setting, basically. Dr. Khatri is a residency program director for emergency medicine at the Indus Hospital Health Network in Karachi, Pakistan. He also is a fellow of IPSS-INSPIRE Fellowship in Pediatric Simulation and currently co-chair of the IPSS, which is International Pediatric Simulation Society Academy. He has an impressive track record in simulation-based education. He has been a dynamic facilitator and educator across multiple programs, including the certification in EM, the foundation program in pediatric emergency medicine, the collaborative advanced trauma course, and simulation instructor development initiative at the Indus Hospital. As I know him, I know he's a visionary leader in the field, particularly known for his innovative, low cost, and accessible solutions tailored to low and middle income countries. His work focuses on integrating interprofessional system level simulations within hospital operation to foster sustainable simulation culture in a resource constrained settings. He is also a recipient of prestigious Shed Apps Bursary Award for the Master Debriefer course run in Canada by Adam Chang and his group member, who is considered as a father of debriefing. He also plays a key leadership role as a founding member of the Network of Simulation in Pakistan, which you all heard about in the last session from Faisal, representing CIME Aga Khan University. And today he brings to us a wealth of experience and a forward-thinking approach to developing simulation educator and infrastructures with a focus in a low resource environment. So please join me in welcoming Dr. ADEEL Khatri, and over to you, ADEEL.
Thank you, Dr. Javeen, for that very elaborate introduction. Um, it's very nice to be here, and I'm very thankful to the APPNA MERIT leadership and to Dr. Javeen as well. As she said, it's been 6 years, and we have had a lot of collaborations, and with support, we've achieved what we have till this time, and looking forward to much more in the future. I would share my screen now, if that is okay. Okay,
Yes, please.
right. So please let me know if I am audible and my screen is visible.
Yes, you are audible very well and screen is visible too.
Okay, so Assalamu alaikum everyone, all the participants, Apna Merit Leadership and Dr. Jabeen as well. My name is ADEEL Khatri. I am the Residency Program Director at Indus Hospital. Um, I'm here to share my experience and our experience at Indus on how we have been doing simulations. Just a disclaimer that uh, we do not have a big sim center. So anyone who wants to start doing simulation activities, uh, in a setting where they don't have that kind of a setup, I think it will be a very uh, interesting uh, presentation to look at, and maybe we can collaborate as well. So let me move forward. My thing, I have no financial disclosures. There are a few things that are commercial materials shown here, but they're shown just as an example, and in no way I'm attached to any of those commercial brands. So a brief introduction about my hospital, the Indus Hospital and Health Network. Um, this is the biggest philanthropy-based hospital network in Pakistan, and it's completely free of cost service for the patient, and it totally depends on donations. So we are dealing with a big crunch of resources most of the times, and are dependent on people donating and then utilization of those resources. We have a nationwide presence with 12 secondary and tertiary care hospitals, more than 100 primary care clinics, 4 regional blood centers, 13 rehabilitation centers, boat clinics, mobile vans, and container-based community health centers. Um, on an average, more than 5 million patients annually are treated at Indus Hospital in different parts of the country. So the hospital that I work at is the Karachi campus. This is the flagship hospital of Indus Hospital. We had the older building, which was 300 beds, and now the newer building, which you can also see in my background, the bigger one that's there behind the smaller building, that is now functional and slowly building on from 300 to 1300 plus beds. It's a big task, and we receive patients from all over Pakistan. And to deal with those numbers and to have quality care delivered to our patients, what we have is programs that we include as or as a capacity building. So my department, the emergency medicine department, is currently a 48 bedded uh, facility with 6 resuscitation beds and 12 pediatric beds. And we see more than 700 patients a day, and out of those, 30% are pediatric patients. We also have set up a tele-emergency facility for our network. Currently, we are facilitating our colleagues at Gwadar and Badin with this tele-emergency setup, where our senior doctors are there 24/7 to help those healthcare providers with expertise, as they don't have any senior members of faculty over there. So increasing the footprint and allowing them to have better uh, facilities for the patients by delivering capacity building measures for them. So, we've talked about how we are focused on capacity building. So, we have different certification programs which include CPEM, FPEM, CPCOM, CATC, and BEC, which is the Basic Emergency Course, which is uh, a WHO-based course as well. Incorporating simulations into curriculum, and then having all these doctors in the peripheries and those who are working without any formal training program like CPSP based FCPS or MD programs, the non-training doctors, all these programs are focused on that. We also have a formal FCPS in emergency medicine program that is very focused on simulation based training as well. So, why simulation based? Why we focus on simulation based training? The old saying, practice makes perfect. But we can change that now, and we can think of it as a well designed, deliberate practice model makes perfect. That means that the training has to be focused, training has to be learning objective based. Practicing like the old times that happened was practicing on the patients led to variable results as well as um, certainly endangering the patients as well. So simulation gives us that platform where we can design that activity to deliver the learning experience that is required. Where it can be used, it can be done at the undergraduate level as a continuous or in service, um, as a team training, and then competency assessment as well. The best part in simulation is that we can work as a team just like we would in our practice. Traditional medical college education educates us, gives us the knowledge, but it never tells us on how to deal with a nurse or any other people who are working with us. So we have a transition from the traditional healthcare education system towards a simulation based system in Pakistan, but the speed on which this is going on is really slow. There are centers of excellence in simulation, uh, but they can be counted on fingers. And then most of the activities in those centers are limited to that facility. There's a huge gap between where simulation and capacity building is required and where these simulation activities are going on. So in order to bridge the gap, what is needed is a lot of people who know how to deliver simulation as simulation experts and training in that zone. So, when delivering simulation based healthcare education or simulation based activities, there are a lot of challenges that we face. First of all, people have difficulty in understanding on how useful this would be, uh, given that their experience is very limited. Then the pockets of advancement are there, as we discussed, these bigger sim centers, but the spread is not as quick. It is the low resources in areas where it is needed, and then time constraints. So we at the Indus Hospital have tried to bridge that gap by national and international collaborations. We have different programs in collaboration with the University of Pennsylvania, SickKids in Toronto, Emory University and Grady Hospital from Atlanta, uh, national collaborations with Shifa International in Islamabad. We've had a few programs with the Jinnah Sindh Medical University as well as the Ruth Fao Fazaya Medical College as well. So we're trying to get people in and collaborate in order to expand the base on which simulations can be delivered and provide better care eventually for the patients as well. Um, our one focus is faculty development and a culture for simulation where people can understand that simulation based activity, simulation based education, and quality improvement programs can make a difference. And you will see some of our programs that we have done and how they have made their impact. So, our simulation journey, as I may call it, started in 2018 when the formal FCPS residency program was recognized, and we also started the first CPEM batch. So CPEM is Certification Program in Emergency Medicine, and the 5-year residency program, which we do for 6 years at Indus, including the final year, which is leadership-based rotations for our residents. So this incorporates a lot of simulation into our Friday core sessions. Uh, these are the people who are being trained to become national leaders in emergency medicine, and fair enough, they are delivering as in leading roles in different departments all over the country as well. The CPEM program, the certification program in emergency medicine, is targeted towards the so-called non-trainee doctors who are not enrolled into any um, FCPS program or MD programs. This is done in collaboration with the University of Pennsylvania. It is a 1-year course, and we are currently with our 5th batch for this course. Currently, it is a hybrid model. Initially, it was a completely face-to-face delivered in Karachi, but then when COVID happened, we shifted it to hybrid, and how that impacted our practices is something to be seen, and we will discuss as the timeline goes on in my presentation. So we have weekly didactics with online simulations and then hands-on for the um, hands-on skills part spread over the whole year. In 2019, we had the second batch of CPEM, and we expanded to include a trauma course that is collaborative advanced trauma course done in collaboration with Emory University and Grady Hospital, Atlanta. This is an interprofessional trauma management course where we not only have the emergency physicians, but also physicians from anesthesia, orthopedics, general surgery, and the whole trauma team, along with the nurses. This has been replicated in different cities of Pakistan as well as in Vietnam, Ethiopia, Turkey, and Oman. And more than 500 participants to date have been trained through this course. So, in March 2020, when COVID happened, all of our activities at that time were in person, and everything came to a halt. Uh, the first case in Pakistan was in March. So we then brainstormed and thought on how to proceed. And then in October 2020, what we did was we shifted CPEM to a virtual distance simulation. Now, what that meant was we had to do simulations on screens with uh, our participants attending these workshops and simulation sessions at home. Um, we have used different software with regards to this. The one on the top center, it's called Full Code, and we use that for our online simulations in our sessions. Similarly, there's a picture of me standing in front of a camera, and that's another form of online simulation where the participants have joined in, and we are performing live in front of the camera while they are um, giving us the commands on what to do, and that is how simulation with that modality works. So a lot of different juggling with different modalities to carry on with our programs, and this actually revolutionized on our part on how we can approach things and how we can expand. So in 2021, uh, our sessions for the residents, we also shifted them to online sessions. since it was still lockdown days, and we did two online modules for our residents. One was with Sick Kids Toronto. That is where I came first in contact with Dr. Jabin, and we did this very, very effective course for our residents for pediatric emergency medicine. And then the other one was with Emory University, where we did a trauma toxicology course that was also online. Our first basic emergency course, which is a WHO slash International uh, Red Cross course, did we did it in 2021, and that was also online. This is a 5-day course which is focused on emergency management at really basic ground levels. Till date, we have done multiple of these courses. We've replicated this in different cities, in hospitals, as well as with civil aviation people, and with uh, PARCO, that is Pak Arab Refinery Corporation, uh, in Pakistan, where we have trained their medical staff towards providing basic emergency services in very low resource settings. So in 2022, CPEM grew and it went global. So this time we did not just have people joining in from Pakistan, in fact, all over Pakistan, but also a big cohort from Bangladesh as well. So because it was online, we were able to do that, and CPEM then spread globally. Similarly, with CATC, we were able to expand it to first to Vietnam, and then we launched another course that was again hybrid, which was Foundation Program in Pediatric Emergency Medicine. This is again a 1-year course, very similar to the certification program in emergency medicine. This was done in collaboration with Sick Kids Toronto with weekly didactics and a hybrid model where we have simulations every week online and then 4 workshops spread over the whole year where people can join in for the hands-on skills. Currently, the third batch is underway for this program. Now, we've talked about capacity building for the doctors for their skills, but we also said a few words that we want to develop instructors and faculty who can provide simulation based experience. So 2022 was the year when we started our simulation instructors workshop. Till date, 4 online workshops have been conducted and 3 in-person workshops. Um, the, there have been participants from 3 different continents. Again, the advantage of being online is that we can increase our footprint globally. This this initiative is target specifically for the future sim faculty development in low resource settings. And you can see in the pictures these dolls and the mannequin. The mannequin is actually made up of water bottles, those 1.5-liter bottles that we have. And this initiative, this innovation, was the brainchild of our participants who had just attended this workshop for 2 days, and on the third day, they just delivered simulations from whatever they had with them at that time. So, a very, very proud moment for us, and we're looking to expand this program even further. Then we had emergency leadership course. So now we're getting out of the emergency medicine clinical simulations part, and we're delivering this to the leadership for EM. Um, this started in 2022. This was a 5-day course, and it is now conducted every year. It includes a lot of simulations, tabletop exercises, and is targeted towards physicians, nurses, and HODs who are in leadership roles within in emergency departments all over Pakistan. In 2023, KHATRI expanded further to Ethiopia, Turkey, and then we started another program which was CPCOM, the certification program in clinical operations management. So these are not clinicians, these are clinical operations people, and this course is based on the management side. So this is a 6 months course, online didactics, and a lot of simulations, including what you can see one of the pictures. We have a mountain with bridge and a national level catastrophe and how they would manage that. And there was a lot of we simulated flooding and bridge collapses, food shortages, and it was a very nice fun activity as well as a very good learning experience for everyone, including us who are doing this. So in 2024, this was the year when we started shifting to the new building. If you can see my background, there is one building that is lighted up. That is the older, smaller building, and the one in the background, the bigger one, is where we are currently slowly moving. So shifting started in 2024, and the emergency department was the first one to be shifted. So what we did was that before moving in, we did a full simulation of our emergency department with the patient loads and to see how workflow will go in the new building just before being shifted. So what we did use in this was toys like Lego figures and QR codes and Google Forms, and we then generated around 150 patient profiles to run in the simulation, creating a situation of ED disaster and see how the systems would work. This helped us in determining the workflows and latent safety threats before the actual move, and we were able to mitigate a lot of these issues before we went in. So a lot of simulation activity, but our biggest challenge is that simulation is costly, and that is what we hear. Um, Solution is that we just need a bit of creativity and what we call in Urdu jugaad. So not necessarily a bad word, but it helps us to do what we want to do with the resource constraints that we have. So I'm just going to present a few, if I may say, jugaads that we have done in order to deliver a good simulation experience to our participants in all these programs. So this is what we would recognize as a laundry brush that we clean our clothes with. We use it as a defibrillator paddle when we pair it up with an iPad that has a defibrillator rhythm going on in it. Simple but effective solution. Difficult airway training. This is a styrofoam block, and we've put a ventilator tube, the attachment tube that is there as trachea, and on top of it, we've applied a foamic sheet to give the feel of a skin, and we have a difficult airway cricothyroidotomy model ready for the learners. Toilet roll, balloon, and glove. We have the R model. You put the cannula in correctly and blood comes out. Intraosseous line placement, some plaster of Paris wrapped around rolls, the toilet rolls, and we have a bone that we use for intraosseous line placement. wearable gloves for our actors or simulated patients where tendons are visible. These are actually toothpicks and very effective when we're doing trauma simulations. And active bleeding when we connect it to some pipings so they can control bleeding. Lumbar puncture model made up of those clips that we hang clothes with, put it in a box, and we have a spine and lumbar puncture model. When needle is placed correctly, CSF comes out. A baby delivered from a pajama model to train our doctors for deliveries, shoulder dystocia, the umbilical cord wrapped around the neck, those kind of emergency situations. Eye models developed on paper cup for lateral canthotomy and simple medication pack with a hole in it and a picture of retina inside to train doctors to have those movements that they would that would help them in to correct fundoscopy or retinoscopy. Pus-filled small balloons simulating as peritonsillar abscesses and drainage of those abscesses, and then using toys and QR code profiles for a full disaster ED simulation with data tracking and patient movement to provide the operational indices and results that helped us to mitigate the latent safety threats before we moved in. Ultrasound guided central line placement made with kitchen sponge, balloons, and paper straw. So this is a model that we presented last year at the International Pediatric Simulation Society conference, the IPSSW in 2024, and we won the Best Innovation Poster award in that conference as well. So over the years, we have a few publications relating to simulations with our programs, the clinical outcomes of CPEM, then the one-year training program that is also for the evaluation of learners and program outcomes that is also from CPEM. Simplifying complexity science principles in healthcare using simulation as educational method, and then cultural sensitivity, where in uh, the pediatric model, the pediatric module that we did with our residents, we had fellows of pediatric emergency medicine from sick kids, and then um, we tested the cultural sensitivity part in that module. So these are the few of the publications, and we are currently working on a few for, especially on our models that we have developed, and those um, projects are underway and very soon to be published, inshallah. So our future goals to continue capacity building, focus on research because that is where the improvement happens. That is where we know that our solutions are working or not. So focus on research, representing Pakistan and Indus at international forums, collaboration with national and international institutions. We've had good collaboration with different hospitals and institutes from all over Pakistan. Um, Simulation certification program is currently under development, and we have now started talks into the MHPE programs to include simulation in the Masters of Healthcare Professional Education programs as well. Overall, what we would do is we would like to create an impact that is much larger than us, just like the shadow of this pawn is much larger than the pawn itself, and to prepare the new generation of sim educators and inventors. The pictures show two of my residents, and this was like 3 a.m. in the morning, and They had a little break from the patients at that time. And what they were trying to do was to make a model for controlling peripartum hemorrhage, a topic that was to be discussed 2 days later. And they were trying to make a model on how to teach the whole group of residents practically on doing that. So, a very, very proud moment for me that the newer generation has gotten into this and are planning and thinking to improve the situation in Pakistan. So, with that, I would like to thank you all for your patient listening and would like to open the forum to the facilitators. And any questions, please feel free to ask. Thank you.
Thank you so much, Adil, for like literally giving me a glance where we started and where we are. Such a proud moment, and I feel so much humbled to be working with you. Thank you so much for presenting this. Adil, do you want to unshare the presentation so that we
Yes,
all
sure.
can see each other? With this, I will pass it on to our panelists to provide some comments. I see already Dr. Akhtar has unmuted himself, so go ahead, Dr. Akhtar.
Adil, such a wonderful presentation, especially showing how you guys have been, working without resources, or perhaps amplifying some, what you use the word, typical Karachi word, jugaad, and trying to, continue the journey. And remember that all the people from Silicon Valley who has started some big things always started their garages, and they come to a level where the whole world know about them. Indus, as you know, is one of the wonderful product happen in the world, which is hardly matchable. There are one or two projects like Indus is around the world, and I'm also proud to be a volunteer of Indus. Now, my one simple question: I see that you guys are working and doing a lot of academic work as well. It's not that you are just trying to do one thing. I'm seeing FCPS, I'm seeing PAM course, I'm seeing PAM certificate course, I've seen this also the leadership course. Me as a student of pediatric emergency medicine, I think it's a great effort with the limited resources. One thing, there are a lot of listeners here, a lot of people who has connections with their academia and their institute. Although you mentioned in your slide, if I ask you to simulate a model of a simulation room where you can have like a flagship room, where what do you think your budget could be or would be to make a model room of simulation in Indus, like a first block of a simulation, model where you can start from there propagating?
Right. If I can answer that in a way, in what is the budget that is required for anyone to create a model? Would that be fine?
Sure. Yeah.
Right. So basically, it all depends on the learning objectives, what we want to teach. Simulation can be done on pillows. So anyone who is here and from a low resource setting, please don't get discouraged by the fact that I need a bigger budget. You can do it on pillows. It's just that you need to be clear on what you want to deliver, have some ideas, have like I had Dr. Jabeen with me, and whenever I got confused on how to do things, I would ask her and then think about it and then come up with a solution on how to do things. There are a few other models that we have not shown here as well, like our chest tube placement model, which is actually made up of laundry baskets. So traditionally, either it was done on patients or on goat or carcasses. Um, Frankly, very costly. because you have to get a new goat every time, and that is very costly. So for us, getting those two laundry baskets was a one-time cost. It at that time cost us around 1,500 rupees, and since then we have those laundry baskets, and we've been using them in all of our programs. So that is that. If you're talking about creating a space where you would have the inventory, um, again, I wouldn't, to start off, I would say, because I'm talking about low cost, and I'll give you one more solution that I've just been able to complete the last week actually, was to create a crash cart. There was a crash cart that wasn't working. I got hold of that. It had a few broken wheels and the drawers weren't working. I said, can I have it? And good enough. Our nursing people said, yes, this is otherwise going to trash. I got it. Um, got the materials. Again, there are uh, expired vials and all those things, and made the whole crash cart. So now, since last week, my students are actually, they have a crash cart along with the simulation experience that they have. Commercially available mannequins. We've got the traditional lardel and kumar mannequins, and then it depends on what you want to simulate. If you want to go like medium or high fidelity, like the blinking of eyes or sweating and all those things, they're very costly, like hundreds of thousands of dollars. But there are now cheaper options available which don't give you that kind of fidelity, but they are equally as effective. Um, so they cost around, well, I saw a few from China. With shipping and everything, they would cost around 250,000 rupees, something on those lines, like $1,000 to $1,500 per mannequin. But sir, it mainly all depends on two things. First is, what are your learning objectives? And the second thing is, um, how much fidelity you want to put in, and then you can
Thank
manage
you
to.
very much. Let me ask you, phrase you again the same thing, because I want the listener to understand and may be able to help, Indus in a way. Say, for example, you are teaching an emergency. I think emergency medicine has, when you can do simulation for orthopedic, you can do simulation for surgery, you can do. I'm not talking about that. I'm just talking about the one which you needed to learn emergency medicine course, like a first 8 chapters of a book where you do the emergency simulation, all those using the mannequins for chest compression to defibrillator and IV line, this line, that line. So with a medium level, is it you're saying going to say, okay, if I get 20K or if I get 50,000, then I can put up a nice medium, not very high end, but something which is better than having nothing or going through our limited resources. This will put us in a framework that, okay, we can start thinking that how we can, vouch for that. Me and Jabin can also try to connect with others and see if we can seed something on the first simulation room with a medium for the only for the emergency medicine teaching and training, because as you know, obviously you better know that there's a big flux coming through the emergency department of Indus. And if we are able to teach and train and make them more responsible how to tackle those emergencies, that would be, I think, would be our first goal to, have the resources ready.
Right.
Yeah.
So in that aspect,
Thank you.
Dr. Bean, you were saying something? Yeah.
No, no, go ahead.
So in that aspect, from where I see, if we were going to do a low medium kind of a thing, I think the cost would come somewhere around 2025. 500K USD, if you're going to buy and provide that kind of an experience for the learners without
Yeah.
any big jugards, I would say. Yeah.
Yeah, thank you,
Thank you.
Adil. It's very helpful. So the point which you are trying to make is big sim program can be run with a small space and with a very low cost. But yes, ultimate goal is based on when you start showing your hospital management these impacts, that they are ready to find some funding to invest in an important area of education and faculty development, which always go the least priorities for the leadership when it comes to development, keeping the hospital environment, making the other facilities available. So this is kind of your showing the hospital administration that how it is important and what value does it have. I think I will go to Dr. Sarvat for his comment, and then there are a couple of questions in the chat which I really want to have your views, Adil, on.
Ji, Assalamu alaikum. Excellent,
Walaikum
excellent
salam.
representation, and especially my hats off to everything that Indus Hospital people do, and really unique a place. And I'm a supporter of Indus Hospital. So, just for the since we've been talking about the emergency medicine, let me just widen the horizon of our discussion and say, what is simulation? Now, we, in ordinary life, all the dramas that we watch on the television is actually a simulation. So try and understand that simulation is not like a small box in which you have to specialize, number one. Number two, the Western approach to everything is capital intensive because that's how the capital societies work. And what the doctor has shown is really an outstanding, outstanding example of innovation. I would not say the word jugaad, but that's an innovation. Maybe we'll do a translation of innovation is jugaad. But in any case, this is really really fantastic. The third thing is I would say that simulation is really different for different departments. Every department has their own simulation based on the steps of learning, especially, for example, in radiology, you'll have a simulation of gel blocks, teaching people how to do a biopsy, for example, or drainage, or put a chest tube, or ablation, etc. The other point I quickly want to say that I think this may be a time to write up articles and even book on simulation of so that one of the ways of teaching people is to write articles on it and actually publish it in the relevant literature so that the West may not benefit from it, but say 70% of world population does not live in the West, and they're the one that need these kinds of educational tools. And I think publications of this kind can circulate. I'd be very happy to help out with that. And and the material is such for every department, enough material to publish a book of maybe 600 pages. The last item is that in simulation, it is not only the procedures, and I think in simulation, the processes is also important to bring the teamwork together. For example, in an emergency, a triage as to how to triage patients is a kind of simulation in the sense that will save lots of lives. So these are my comments, and once again, my hats off and compliments to Dr. Presenter and Dr. Jabin and everyone who is doing this fantastic program. And my compliments to Uzair Sahab, who is not here, but nevertheless, he is the
Yes.
father of this program. Thank you very much indeed.
Thank you, Dr. Sarvat, for your valuable comments, and me and Adeel are working on publishing a couple of things, and we will definitely ask for your help and guidance in that. And thank you for mentioning Dr. Ozair. He was away, and he's away, I mean to say he's traveling, and he could not join. Without him, this whole forum will not be possible. And I would like to tell you, Adeel, there's a loads of appreciations that are coming up in the chat with it has fascinated so many people, and they are asking how they can join the courses that are being offered at the Indus. There is a question also that what is the way to join, what is the criteria. There's an Ada from Nigeria, and she is willing to collaborate and attend some of the session so she can replicate some of the similar kind of courses that the Indus is offering. And I am connected with Ada, and I will connect her with you so that you can talk to each other together. So with this, like, can you tell us how the learners can join these courses, how they can be informed, etc., etc.?
Right. So we have all of our courses lined up at the Indus University Hospital website. I'll just put the link in the chat shortly, and you can go there and you can click on any of the relevant courses that you're interested in and get in touch with us. You can also get in touch with me on my email address, which is adeel.khatri. I'll put it on the chat now. At
And there are comments here that yes, there are some benefits of low fidelity simulation, but there are some of its nuances. And as Adeel is saying again and again, I heard him saying it all come down to what is your learning objective? What are the objective you are planning to assess? If that is not matching, then definitely it will turn into not the way you are intending it to turn. So there's a comment here, Adeel. Do you want to comment, because I know how passionate about you are about that? The If you have low fidelity simulation, especially in the assessment, the candidate it may not lead to the expected outcome. And we have this discussion for hours, and you have some of the ideas. Can you tell us, because this is I think last exam of emergency medicine through CPSP. Adeel has revamped it by using lots and lots of simulation. So I would like him to comment on that.
Yeah, for simulation to be part of assessment, be it at any level, the the candidate has to be familiar with what they are dealing with right now and how that relates to the real patient. So you just have to give them a brief introduction to the model itself. That's the first requirement. Otherwise, they may be able to grasp the connection, may not be able to grasp the connection. Sometimes it is just very obvious, even though if it is a very low fidelity thing, like you have a pillow where you have drawn some ribs and you've told them that this is a case of tension pneumothorax. I'm just putting emergency medicine in because that is my field. So tension pneumothorax, and they they are supposed to do a needle thoracotomy. So that is an obvious thing, is that you tell them, okay, this is the patient, these are the ribs, and you tell them the case, and then they have to do that, and they can. It's very obvious. The problem comes when there is a lot of tech involved. So when there's tech involved, then things oftentimes goes wrong unless the participant is fully aware of what is the capability of those mannequins and what where it's not there. So having said that, we've always done simulations, like from first year where we used to do anatomy, and then practicing on each other, the physical examination part, all that traditionally we've been doing this. We did not have any patients, but I remember all those percussions that I practiced on my friends on how to do it. So sort of we've been doing that. But for purposes of having it in the exam, it's very important for the participant to know exactly how things are working in the simulation. Otherwise, it would not give us good results.
Perfect, great. There are people asking about the internship program for undergraduate. So they can always go to the Indus Hospital website. Adeel,
Yes,
do you have a
yes,
specific place
yeah.
where they can
We
all go and look at the details,
Yes, it
please?
is. It is on the Indus University Hospital website. We have a very good program for undergraduates, especially in the summer months, where a lot of undergraduates come in, both from Pakistan and from abroad. So open to everyone.
Great. Thank you so much. I think I have asked all the other questions. Any last minute thought? We still have 2-3 minutes. Yeah, Dr. Akhtar, go ahead.
So, Dr. Adeel, in terms of providing services at the moment in the hospital, and you have already mentioned that we are gradually transferring from the older campus to the newer building. Um, are you also helping the other departments in terms of teaching and training, like
Yes,
orthopedics, because what we have understood from your presentation, that there are, it's a crunch of resources limitation. So can you elaborate a little bit how these are being taught, or how somebody from outside can join you, especially they have skill sets, and not everything is the money driven, but if somebody want to participate with the skill set of their simulation, or to some extent across North America, and so then the entire team can get benefit.
right. So with regards to collaboration with other departments, we've we have some interdisciplinary programs where other departments have joined, but recently we've had a very good collaboration with the nephrology department. In fact, their last Pakistan Society of Nephrology conference, we had our central line model there. Two of my senior residents went there to on that station where there was this workshop, and they were training people to pass central lines and double lumen catheters under ultrasound guidance. So that was that. Then um, now what we are trying to develop with the nephrology department is a simulator for ultrasound guided peritoneal dialysis catheter placement. So that is currently what we are working on, and we've been open to all the departments. They've not most of them have not come to us, but what I've seen is most of the departments before shifting ran some sort of simulation. So I am happy that the culture is developing, and they actually did some form of simulation before coming in.
Thank you.
Great.
Thank you.
I think we are at time. So with this, we will close the session. And still, there are some questions are coming in. Adeel has put his email address in the chat. Adeel, please put it in the chat again so that they will connect with you and ask about the courses. You have instilled a lot of interest among everyone to attend these courses. So you are going to get a lot of inquiries. With this, thank you so much, everyone, for participating. Stay tuned with us for more of such session, and we will continue learning together, building this community of practice together, helping each other, and supporting each other as well. With this, thank you so much.
Thank you all.
Thank you. Dr. Akhtar, can you stay for a minute? We can just do the debriefing. Waleed, can you close the session and bring us